Hey everyone, my name is Michaela West. This is my case presentation for NURS 6400 at Middle Georgia State University. This semester I'm doing my clinical rotation in orthopedic hand and upper extremity surgery, and the case that I chose today was a flexor tendon laceration with possible nerve repair and a complex wound closure of multiple digits. This patient's chief complaint was pain in the right hand, specifically at the base of the index, middle, and ring fingers following a traumatic injury. This patient was a 48-year-old right-hand dominant male patient who presented to the ER following a traumatic hand injury involving the palmar aspect of the right hand at the base of the index, middle, and ring fingers. The laceration was open and approximately 2 inches across the distal palm at the base of those digits. Orthopedic hand surgery was consulted, and upon assessment, the patient stated that this injury had occurred approximately 2 hours ago, in which he irrigated it, rinsed it out, and wrapped it with a towel in order to stop the bleeding at home. Upon assessing the patient, we reviewed surgical history, which included a knee scope with a medial meniscectomy, which occurred in 2018, and a wisdom teeth removal that occurred in childhood or early teen years. His medical history includes hyperlipidemia and diabetes mellitus type 2. Social history states that he is a current smoker and that he smokes approximately a half a pack a day, moderate alcohol consumption, moderate caffeine intake, no illicit drug use, and moderate to high activity level, especially at work. Family history: his mother passed away from a stroke. His father has hypertension, hyperlipidemia, and diabetes mellitus type 2 as well, and his brother just has stage 1 hypertension. Upon further review, we reviewed his home medications. He states that the only 2 medications that he takes on a regular basis are atorvastatin 40 milligrams daily and metformin 500 milligrams PO twice a day. He states that he also takes Tylenol or ibuprofen PRN for pain. Upon assessment of this patient, we did choose to do a more focused exam focused on the musculoskeletal, cardiovascular, neurovascular, and lymphatic systems of this patient, which are discussed in more detail on the next slide. But a general overview of systems for this patient: he was stable, he was in no acute distress at the moment, no fever, chills, or unintentional weight loss present. He was in no respiratory distress, cardiovascular distress, no nausea, vomiting, or diarrhea. He did complain of pain in the right hand, in which radiated into the forearm, and in the right hand he also had the lack of flexion in the index, middle, and the ring fingers. Lymphatic system: there was edema present over the palmar aspect of the right hand, and there was no lymphedema palpable at the time of the injury. For immediate treatment, we chose wound irrigation and closure in the emergency department with a dorsal blocking splint in order to hold the fingers in slight flexion, and to send for surgery following medical clearances to the outpatient surgery center the following day. Pain management with Norco 7.5 to 10 milligrams PRN for pain while the patient waited for his procedure. The following day, we saw the patient in the outpatient surgery center for a scheduled procedure, in which was posted as a right hand index, long, and ring finger extensor tendon repairs with possible digital nerve repairs, wound irrigation and debridement, and a complex wound closure. Following the irrigation and debridement in the ER, we performed a more focused physical exam on this patient, which included assessing for FDS and FDP function. There was evidence of FDS and FDP function, which are the flexor digitorum superficialis and the flexor digitorum profundus to the right index and right long, and an isolated FDP injury to the right ring finger, which is also called a jersey finger. There was no bone exposed and no evidence of fracture on X-ray in the emergency department. For neurological, the patient was also complaining of numbness to the medial aspect of the index finger, which led us to believe that there could be a digital nerve laceration as well as the flexor tendons. Lymphatic, as we talked about earlier, there was moderate swelling over the base of those fingers. After irrigating and debriding and cleaning up that hand, we were kind of more able to see that the swelling was localized to the area of the trauma and that it was not spreading. The diagnostics for this patient included x-rays, which included no evidence of fractures or dislocation on films. For the pre-op, we also just did a basic CBC renal panel just to make sure that his electrolytes were stable in order to proceed with surgery. Upon seeing this patient, my differential diagnoses included flexor tendon lacerations of the right index, long, and ring fingers, digital nerve lacerations to the right index, long, and ring fingers, and possible metacarpal fracture, displaced versus non-displaced, prior to getting films. The actual diagnosis for this patient include flexor tendon lacerations of the flexor digitorum profundus of the right ring finger or jersey finger, a flexor tendon laceration of the FDS and FDP of the index and long fingers, and a digital nerve laceration on the right index finger. So our treatment plan for this patient. So we did complete the surgery the following day after seeing this patient in the emergency room. We performed a right hand index, long, and ring finger extensor tendon repair with possible digital nerve repairs, in which we did repair the nerve on the medial aspect of the index finger. We did an irrigation and debridement and a complex wound closure using chromic gut suture on this patient. For post-operative management, we did this procedure outpatient at an outpatient surgery center. So the patient did get to go home, but they did require post-anesthesia monitoring with discharge to home. We had our DME come and apply a dorsal blocking splint to maintain finger flexion in order to not damage the repairs that we did on the 3 extensor tendons of the index, middle, and the ring finger. We prescribed Norco 10 milligrams, 325, PRN for pain every 4 to 6 hours. Patient teaching that we gave to the patient includes not getting his splint wet. We explained how sensation returns after doing a nerve repair. Typically for the hand, nerves tend to regenerate at about 1 centimeter per month, and that numbness on that medial aspect of the index finger was normal and to be expected. We also explained to limit activity and avoid strong arm flexion. Anything that fires up those flexor tendons we need to avoid on that right side. We also discussed smoking cessation for this patient in order to promote wound healing because he had a complex wound closure. We took him out of work for 1 month. At our 1 month appointment, we're going to reevaluate, see how he's doing, and continue to work on his work status. He does have an appointment scheduled for his initial post-op 2 weeks after in order to assess those sutures. The sutures that he has in can come out 14 days after, but the complexity of his wound may require him to have the sutures for a little bit longer period of time in order for that tissue to heal properly. Following post-op and the initial 2-week and 4-week post-operative appointments, we do send these patients to therapy beginning at 4 weeks or depending on the progression of the patient. It is very important to have these patients in physical therapy and occupational therapy because the patient is unable to flex the digits where the lacerations occurred, and remaining in a dorsal blocking splint highly limits mobility while protecting the repair. So getting these patients into OT and physical therapy helps them to regain the mobility in their hand. Also helps to decrease swelling. Our therapy department does therapies such as dry needling, ultrasound, and progressively and safely works on mobility of these patients in order to ensure a safe recovery. And these are my references. I really hope you guys enjoyed this presentation. If you have any questions, please leave me a comment on this video and I would be glad to answer them all for you. Thank you so much for taking the time to listen to my case presentation, and have a good rest of your semester.